Hi, everyone. Welcome. Feel free to introduce yourself in the chat if you like. We're going to wait a few more minutes while folks are still joining. All right, I'm going to start to go over a few logistics. I want to be cognizant of everyone's time, and thank you all for joining us today. This is the town hall with the Los Angeles County Department of Mental Health, as well as SAPC that handles the substance abuse for the county. And we're going to be going through an overview of the changes with the expansion of grave disability with SB 43. It's going to be a presentation followed by Q&A, and feel free, if you do have questions as the presentation's going on, to put them in the chat, and we will be answering questions at the end. We'll also have opportunity for you to ask questions verbally, so feel free at the end of the presentation to also raise your hand, and we'll invite you to come off mute to also answer any questions that you may have. So with that, I would love to introduce our guest speakers. James Kwon is the Deputy Director for the Los Angeles County Department of Mental Health. He received his Bachelor's of Science in Psychology at the University of California, Davis, and had previously worked for the County of Santa Clara as the Supervising Deputy Public Guardian and Orange County as Deputy Public Guardian before his role at the Los Angeles County Department of Mental Health. Dr. Brian Hurley is the Medical Director for the Substance Abuse Prevention and Control at Los Angeles County Department of Public Health. He received his MD in medicine at the University of Southern California and has previously worked for Los Angeles County Department of Health Services as the Director of Addiction Medicine and Los Angeles County Department of Mental Health as the Medical Director of Co-occurring Disorders before his role at the Substance Abuse Prevention and Control at Los Angeles County Department of Public Health. So join me in welcoming them both and thanking them for this presentation. And with that, I'm going to turn it over to James.
All right, thank you, everyone. So hopefully we can monitor the chat and trying to encourage, collaboration and questions during, if possible, and then we may end up covering it as well. So I know that's it's a science and an art when to ask a question, right? So we want to be understanding of that. If it's burning a hole in your pocket, please get it out before you forget. But please be cognizant we may end up answering it as well. So we want to thank you so much for joining this evening. And I think also to Dr. Hurley, we have a pretty good repertoire, I feel like, between the two of us.
Yeah, indeed.
So please cut in when you think, especially from your point of view, something pertinent you want to point out during some of the legal stuff that we're going to cover. So SB 43 passed several years back, but LA County needed some time because we are an enormous county to train everyone and get everyone ready for this new statute. So we're going to cover some of this. I just want to let you know, the slide deck was actually prepared to train the people who actually write holds. So it's a little bit more dense than some of the people who are on the call may want to see. So you're going to get the slide deck, but I am going to gloss over some of the points. So if you end up having questions on them, we'll be more than happy to answer. But let's kind of move forward. So, we'll kind of go over LPS overall as well, and then understanding what the changes are and how it may affect people in the community. We'll go over kind of what the major issue here is. They changed the definition of grave disability to include a couple more things, right? So we'll go over that and then how that changes, not just, the different holds, involuntary holds that a person can be put on when they're in crisis, but also how it changes conservatorship, but also, what that means, one of the additions is people who are solely dealing with severe substance use issues. And there's a lot to unpack there that Dr. Hurley will expertly go over, and quite engagingly, may I add. And I think even for us on the DMH side, the SUD component, the resources, what you can rely on, and like what the current practices are, those are some of the more challenging issues, actually, even for the clinicians out there. So I think we do want our NAMI community and family members to be aware, it may not be what you think it is based on what you watched on TV or, in past practice. So I'm sure it'll be very engaging. And then we'll talk a little bit about the other alternatives to conservatorship that potentially might be in play as we move forward. So let's kind of move on. So if you guys know, the LPS Act was enacted, and this is kind of personal opinion, so please don't, again, it could have been different, but the legislation really was designed so that people have their due process rights respected before they're involuntarily committed. So if you remember, at least movies, because I wasn't around for the 30s, 40s, 50s, but if you remember in movies, there's some movies where, historically it's like a husband and wife couple, and then the husband feels like their wife is acting erratically, and they'll just commit their wife to a facility. Like, we've all heard stories where without their rights, some people can be committed. And this was an act to kind of really safeguard people's rights rather than first and foremost to deliver community mental health services. I think maybe the state never fully got around to backing up all the other beds that were lost in the transition out of those involuntary commitments. But that's what the reasoning for the LPS Act was to give people due process rights during involuntary detentions and treatment, right? So under LPS, individual can be put on a hold, can be evaluated, and then if appropriate, detained and taken to a facility for further observation and treatment, right? One of the things there is after a certain amount of days, that person needs to be able to exercise their rights to be able to contest that if they do have the capacity to do so. And that's really the main intent of the LPS Act, other than to also provide people a mechanism to give involuntary treatment. So that's the LPS Act in short. It kind of breaks down, before we go into SB 43, it breaks down into various different days of holds, right? So some of you in the community may be familiar with the term 5150, right? So that's a 3-day hold a 3-day maximum hold to hold somebody, see if they, have observable conditions where a clinician may be able to diagnose them, give them treatment, and then if they need more treatment, they can go on to a 14-day hold. And then after that, another 30-day hold. And then you can actually do another 30-day hold on top of that. So that's 77 days of involuntary treatment that a person can go through without necessarily needing a conservatorship. So I know that's the other reason a lot of people might be here is like, what are the pathways to conservatorship? And, you have all those holds in place before a conservatorship is even initiated, right? So since the 60s, SB 43 is really the biggest change to the LPS Act. It was signed back October 10th, 2023, and we enacted it here in LA County on January 1st, 2026. So it updates and expands the definition known as grave disability. Don't worry about the hearsay rule in conservatorship hearings, but it did make some other changes in regards to impacting conservatorship hearings. So moving on, it changed the definition of grave disability, which means prior to this, someone could be considered gravely disabled if they either had a mental health disorder or co-occurring severe substance use disorder or mental health disorder. And due to that, they were unable to provide for their food, clothing, and shelter, right? And so SB 43 added some criteria. It included individuals who have solely, right? They don't have any other mental health nexus, solely a severe substance use disorder to be able to qualify for a conservatorship. And then they also included these definitions of personal safety and necessary medical care. So I mentioned food, clothing, and shelter as the things that a person would be unable to provide for themselves because of the mental health disorder. Now you've added two other definitions, personal safety and necessary medical care as basic needs that a person would not be able to provide for themselves due to their mental health disorder, and now also standalone substance use disorder. So it added one more diagnosis and then two more categories. So I think we have it kind of bulleted a little bit easier, but this is the past definition. This is the current definition. I'll move on. You guys will get the slide deck. So this is kind of how you can see it, right? You previously, we could not use severe substance use as a reasoning where someone, if they couldn't provide for their food, clothing, and shelter because of a severe substance use disorder, they would not qualify for a grave disability hold or a conservatorship. Now they can, right? And also, if someone can't provide for their own personal safety, if they can't provide for their necessary medical care, regardless of those two diagnoses, now they do qualify. So it added a few extra elements. Maybe this is a good time. If there's anything in the chat, I mean, this is usually where we get questions, but we'll kind of move forward. So expanded the definition, right? We're going to talk about severe substance use disorder. I'll say the layperson's aspect is all I remember is 6 out of 11, right? I'm not a clinician. There's 11 observable conditions apparently, and you have to qualify for 6 of them, right? But I think the other thing we do want to note before Dr. Hurley kind of takes over is, these are just like very loose observable conditions. So let's say you see someone in a crisis and you need to call the police, right? The police are not going to come and figure out just like, well, hey, which of these 6 of the 11, or is it a psychiatric crisis? Or like, it'll just be that someone's in crisis and they meet, whole criteria. Usually either they're a danger to self or a danger to others under the 5150. So, some of you guys might be wondering, like, how will I know what a severe substance use? That is really up to the clinicians once a person really gets to a hospital or a facility. So, we've gotten a lot of questions about that. You don't have to rack your brains too much, although Dr. Hurley will go over that.
Sure. Actually, could you go back to the table? Thank you very much. I put in a link in the chat to the SB43 website. So in addition to this slides, I just wanted to highlight there is actually a website that has like frequently asked questions and guidelines, and we put together a number of materials because the county did work for a bit on this, including information sheets and toolkit documents. It's all posted on that website, in fact, including this very table. So in addition, of course, to the slide deck, I did want to highlight the additional county website where you can get more information. Thanks for advancing to the next slide, James. So the DSM-5 is basically the book of psychiatric diagnoses. It includes a diagnosis of what's called a substance use disorder, as James mentioned. Now, the way the DSM is written, it's written for clinicians. And just to be very clear, SB 43 is being implemented with first responders. It's not everyone that places a 5150 is a clinician. And so the adaptation with the way that this is being applied is the person applying a 5150, considering whether somebody has a severe substance use disorder or not, is not based on a complete history. It's just based on, at the time of their presentation, is it more likely than not that somebody has a substance use disorder that is driving the grave disability? And that's, I think, one key element. Substance use does not mean you get placed on an LPS hold. Grave disability is why you get placed on an LPS hold. Grave disability, food, clothing, shelter, and now necessary medical care and personal safety, right? Those are now the kind of the new components of grave disability. And that's That's a functional thing. How, like food, clothing, shelter, how are able to have, personal safety and necessary medical care. How functional is somebody? If somebody can't do those things, whether it's due to a mental illness, whether it's due to substance use without a mental illness, a severe, let me caveat, severe substance use, but it's not, the substance use is not the reason for the hold, is the grave disability. Next slide. So here are the 11 criteria. And we talk about them as observable, frankly, and now I'm just going to pontificate, forgive me for this. They're not all totally observable, right? So like how much craving somebody has is largely subjective. But if you hear from somebody, I just can't seem to stop, I crave it. Okay, like that would be they probably crave substances. Continuing to use even when it causes problems in their relationship. Continuing to use even when it puts somebody in danger. Continuing to use more than somebody attends to. Somebody begins to give up their relationships. They begin to give up their occupation or volunteer work. They begin to give up any responsibilities they have because of their substance use. They're spending a lot of time using substances, recovering from substance use. People will sometimes say, I really want to cut down or stop, but I really can't seem to not. And continuing to use even as hazardous situations. I know that if I drink, it's going to hurt my liver, but I just can't seem to stop. Or I know if I use methamphetamine, it's going to worsen my blood pressure. I just can't seem to stop. And not managing to do what people should be doing at work or school or home or in their family environment. Needing more of a substance, which is like tolerance, like somebody escalates their use over time, or if they stop using, they go into withdrawal. Those are all features of a substance use disorder. There's 11 criteria. The way the DSM is written, you need at least 6 of these. So it's over half, right? With 11 criteria, 6 or more is over half of these need to be present for somebody to have a severe substance use disorder. And a severe substance use disorder does not mean that you get placed on an LPS hold. What it means is if you have a severe substance use disorder, and that is the causative reason for why somebody is not able to maintain food, clothing, shelter, necessary medical care, personal safety, that's when a hold can be placed, right? So it extends the reasons for grave disability. And so it's mental illness, it's standalone substance use disorder. And what I'd say, because I am a clinician and I see clients, what's more common than not is the combination. You know what I mean? It's the combination of mental illness and substance use that tends to result in grave disability, right? It's not that substance use on its own couldn't, but the truth is, for many people, the time that people are gravely disabled due to severe substance use is usually brief. When I say it's brief, it's when they're using. You know what I mean? If they stop using, then the grave disability goes away because they don't have other like mental illness, or they don't have another reason for why they're gravely disabled. Next slide. Thank you, James. So so that's the criteria. What does this actually mean? So if somebody, let's just say, is slurring their speech, that is not gravely disabled. Let's say they smell like they've just had some alcohol, or they smell like they just used some cannabis or marijuana, or they have bloodshot eyes. Any single one of these is not really a severe substance use disorder. Next slide. It's really like a constellation of criteria that indicate, okay, this substance use disorder is significantly impairing, that it's preventing somebody from food, clothing, shelter, necessary medical care, and personal safety. Next, if you kind of click through, I'll just sort of speak through these. Thank you, James. So multiple contacts where somebody's intoxicated and incapacitated. It's probably not like a single visit, but like somebody is really not able to not use, and when they're intoxicated, they are impaired. Refusing food, refusing clothing, refusing shelter, even if it's due to severe SUD. Unable to manage their hygiene, their cleanliness due to severe SUD, and multiple overdoses. This is the key. Some people do overdose. That is not in and of itself grave disability, right? That could be an error, that can be a mistake. And when I'm talking about overdose, I'm talking about unintentional. I don't mean suicide attempts. I mean sort of unintentional overdose. But if somebody is continuing to overdose again and again, not because they want to die, but just because they can't seem to self-control their substance use, that would all be behavior suggestive of somebody unable to consistently maintain food, clothing, shelter, and personal safety or necessary medical care. And law enforcement, we don't expect non-clinicians to diagnose a severe SUD. It's really to identify and describe what are the observable behaviors that suggest the substance use is severe and causing the impairment, or causative of the impairment. They're not making a diagnosis, but it really does need to consider the individual's entire situation, because I will say, I work, in the health department. There are people concerned. Just like what James alluded to, is SB 43 going to be used to essentially involuntarily commit a bunch of people to use drugs, even if they're functional, right? Even if they are able to, manage food, clothing, shelter, if they're able to, to do those things, are people going to get basically, locked in involuntary settings simply because of their substance use? And so on one hand, SB 43 creates a wider door. If you think about it, this is the door to involuntary settings, and it's a wider door now. But what it isn't is everybody who uses substances now is going to be sort of involuntarily committed. Next slide. So within this context, Los Angeles County has a network of substance use providers. And our network of substance use providers is a different network than DMH's network. So DMH has a network of hospitals and psychiatric health facilities and boarding cares and FSP programs and psychiatric remote response teams and outpatient clinics and public guardian. And James, I'm forgetting a bunch of stuff, but that's like DMH is a big network of care, right? And SAPC has a network of care, and it is smaller. Mighty, but small, right? It is not as many sites, not as many programs, but and there is overlap, right? There's actually, it's interesting, the substance use system and the mental health system do have overlap in terms of who provides care, right? There's many co-contracted programs. But on the substance use end, we have hospital programs that usually offer withdrawal management. We have residential programs, and residential programs are oftentimes how people think about treatment. Somebody goes to treatment, they go to a contained setting where they are in a residential. But I will say, residential is where treatment starts. For many people, it is not where treatment ends. Because after you no longer need the containment of residential, then there's high intensity outpatient where people can be in recovery housing or interim housing or in their own residences, and they can continue to get the hours of counseling and support that help support recovery. And then more general outpatient, which is, outpatient care. We run a number of recovery services, including recovery housing programs that are abstinence-based. The idea is if you need a place to stay where people aren't using substances, we have those available here in LA County. And we have specialized opioid treatment programs for patients who need access to methadone, buprenorphine, and other medication services that are actually federally licensed to manage the full range of medications for opioid use disorder. Next slide. So that's how our network is organized. And you can sort of think about it in the substance system as there's hospitals, residentials, high intensity outpatients, outpatient, and then some prevention, early intervention. That's more or less the different intensities of care. But one principle in the specialty substance use system is that care is voluntary. We don't offer any locked settings of care. And you would say, wait a minute, Brian, doesn't SB 43 say if somebody's gravely disabled due to SUD only? So the state has actually updated LPS licensing standards for LPS licensed facilities to include service standards for people with SUD only, right? So we don't have a current separate substance use system that's locked, right? We work with our Department of Mental Health and our existing, locked facilities to support the provision of substance use services when people are sufficiently disorganized, right? Sufficiently functionally impaired that they need that high intensity level of care. And when people are then ready for a voluntary setting, And if it's SUD only, or if they're co-occurring disorders or not, if the substance use is the driver, and they have co-occurring disorders, but the co-occurring disorders don't prevent them from functionally engaging in substance use care, we have the full range of care available. And actually, there's a lot of patients enrolled in both, right? The mental health programs, the SAPC programs. This is all like how our system is organized. But we use a national standard called the ASAM criteria. And the ASAM criteria is a national set of standards that looks at what's going on with somebody as a psychosocial treatment. And it says, this is the level of care that's most appropriate. So for example, if you are drinking a lot of alcohol and when you stop drinking, you have seizures, you have really high blood pressure, you get really medically ill, you need to go to withdraw, like that could be a medical emergency. You have to go to either emergency room or if it's appropriate to withdrawal management. For people that just can't seem to not use no matter what, residential settings, absence-based settings where you live on the campus where you get treatment could be really helpful. That's where treatment starts. That's oftentimes not like people oftentimes stabilize where they can be in either recovery housing or other housing sites and continue to benefit from outpatient treatment. So that's another example of if somebody can't go to residential for whatever reason, they can receive outpatient treatment from wherever they are to help support their recovery. Next slide. Here's the 6 dimensions. So again, the ASAM criteria, national standard. It includes withdrawal potential. It includes medical needs, mental health needs. How ready is somebody to make progress on their recovery? What's the chance they're going to continue to use or continue to have problems? And what is the recovery and living environment? And those are kind of the 6 components that we look at to help determine what part of the SAPC network somebody should start in and when they're ready to step down to a lower level of care. Because I want everybody to be in lifelong recovery. Like that's the goal. Like just to be very clear, that's the goal. That does not mean lifelong residential, right? That means that they have residential as long as they need it, high intensity outpatient as long as they need it, outpatient as long as they need it, and you can stay in outpatient in perpetuity. Next slide. So this is how the ASAM criteria kind of translates to level of care placements. What does this patient want and why? What are the medications and the counseling and supportive services that are appropriate for them right now? Where can they, at what sort of intensity or dose can they get access to that? But that's the kind of through line between intake assessment, service planning, and level of care placement. Next slide. There's some actual evidence for the use of ASAM criteria. That's why the state of California is mandating it. So you get reductions in no-shows to the next stage of treatment. You get reduced dropout from treatment. You get more improvement in addiction severity outcomes and an increase in the number of people ready for step down to the next level of care. It can be counterintuitive, but keeping somebody in a residential setting longer than they need, people can actually grow resentful, right? People can say, look, like I've been ready to actually have the flexibility of a less restrictive level of care. And yet I've been here for a month and another month and another month. And it can actually, people sort of get this, like, it's almost like treatment exhaustion, right? So the idea is that we're tight, like I sometimes will ask audiences, what's the right amount of care? And I'll get answers like 28 days, 90 days, 1 year treatment. And I say, actually, I want people to be in long-term treatment. I want people to be in long-term recovery. But what dose of residential, what dose of high intensity outpatient, what dose of outpatient you get depends on the person, right? Some people need 2 weeks of residential, they're good. Some people, 90 days is just getting started. They're going to need much longer durations of high intensity residential care. Next slide. This is the service standards for publicly funded substance use treatment. So outpatient is, oftentimes a couple of visits a few times a week. Intensive outpatient is usually at least 3 days a week, if not more. Residential is 24-hour structured environment. Opioid treatment programs are programs that actually will administer medications to people. So methadone, buprenorphine, there's some injectable medications that we can use for opioid use disorder. And withdrawal management is typically hospital or residential levels of care. And then recovery services are sort of ongoing. There's no particular limit on how long somebody can be accessing recovery services in the community. Next slide. Personal safety. James, do you want me to cover personal safety and necessary medical care, or do you want me to turn it back to you?
We can cover it together because I actually, going back, I wanted to double down on
Please.
some of the points you made is, obviously, again, not a clinician on my side, but I think forcing people into treatment is a challenge in terms of outcome. At least that's what every single clinician I've ever met has told me, right? So if they only have a substance use issue, forcing them into treatment where, especially in a locked setting, if that ever ends up existing, I think that'll be very challenging because a lot of the recovery components for substance use is realizing the need for change and like getting to the point where there's a self awareness and motivation to change. The long-standing aspect of LPS, the reason why LPS has at least worked for the people who enter into the system until this point is that involuntary medication works for people who have psychotic disorders to at least get to the point where they have enough clarity to make their own life choices. For example, I ate Popeyes for lunch today. I should not have, right? Some people say I'm risking my health and that I need, but I don't want an intervention because I ate Popeyes, right? But I feel like I have enough clarity to know the benefits and risks of eating Popeyes, and obviously the benefits and risks of eating Popeyes every day for lunch. So I think, although it's, I say it somewhat facetiously, that's kind of line that we wanted to create, because with this new paradigm of treating people involuntarily who only solely have severe substance use issues, I think there is that component that the LPS system is not quite ready to say, well, we're going to put them in the same situation as traditional mental health LPS conservatees. That won't work, which is why you saw the network of care that SAPC provides. And all of them are what you would call open settings, right?
Mm-hmm.
Like they don't have locks because that is not conducive to the recovery model that they're sharing. So, I mean, that's kind of the biggest difference if some people are looking at, okay, I have a loved one, they have a substance use issue, now I need to get them into treatment. But, we do want people to be aware of that element. And then kind of moving forward with the new definitions, I think, Dr. Hurley, it's great that you referenced our website because a lot of examples will be there as to what kind of would make a good legal argument, because in the end, people stay on holds and you need evidence as to their functionality during these holds to move on to the next hold and then move on to a conservatorship if appropriate. And so there are some definitions, but personal safety is probably the most challenging one. But again, these are observable conditions, right? You can't go into the mindset of someone. They have risky thinking, right? Observable condition. And again, a lot of context is needed, even with these observable conditions. Impaired judgment, right? Risky situations. So again, while weaving in and out of traffic, I am a frequenter of walking through Skid Row, not because I have some weird fetish, but like some of the restaurants on one side of Skid Row, and then where I usually park is on the other side because it's so challenging to get there, right? Lots of people are walking on the streets, but in Skid Row, if you've ever been, you know that cars are not driving through at 60 miles per hour. People are very careful. People are cognizant of that as they walk through the streets, right? So it could be someone's weaving in and out of traffic, but, are they gravely disabled because of it? That's a challenge, right? There's a lot of context to it. Someone who's at risk and vulnerable to victimization, that happens a lot. I'll skip anecdotes for most of these, but again, I'm prone to overpaying when there's not a price tag, right? Again, I don't think I'm gravely disabled. Some of you may argue it sounds like you might be, right? But those are where we want to take contextual clues into factors. We do see a lot of victimization on the street. Does the person have the ability to be able to navigate those, or is it just poor judgment? Those are two different things, right? Inability to care for personal hygiene or cleanliness. Some of these are also personal choices. Moving on, you see tents on the streets. It could be a choice. Maybe it is a choice. I think we all need to take these kind of, again, contextually in these situations. So again, in traditional LPS conservatives, you would say, is there an element of like delusion or psychosis that's driving these behaviors, right? Versus personal preference. And sometimes it's hard to differentiate between the both, but that's what personal safety criteria is looking for, is like, are they able to remain safe in the community under relatively normal conditions, right? Even if someone is living on the street. Moving on, this necessary medical care is a little bit simpler in that, you know, there is a code that it refers to in the health and safety code. But basically, it hinges on a couple of factors. It's just, again, observable conditions, right? Again, I had anecdotes for all of these, right? But I actually had food poisoning a couple of weeks ago. It was horrible. I mean, just every place that you could think of, something was coming out of, right? But again, is the person gravely disabled? So for all of these, whether it's malnourishment, coughing and vomiting, blood, seizures and convulsions, you want to make sure that are those things that some person is not treating because they're gravely disabled, like due to psychosis or, you know, some other, you know, severe substance use that's driving their behavior, or is it just, you know, lack of ability to find treatment or whatnot? Most likely they're getting taken to the ER either way in some of these situations, right? But I think for expectations of the callers, we want to be very clear, like that may not be someone who's necessarily gravely disabled just because they're exhibiting that particular behavior. We'll skip the first one because that just pertains to court hearings. But one of the things that SB 43 did change is it requires us, when we investigate whether someone's appropriate for conservatorship, to statutorily, we have to look at other programs first, because again, we want to protect people's rights while still getting them onto a treatment path. So one of the things that we have to do as the public guardian now is, in our reports to the court about whether someone is or is not appropriate for conservatorship, we also have to highlight the point that we have, especially these two programs, assisted outpatient treatment, you may know as Laura's Law, or Care Court, which was recently enacted. It requires the public guardian to investigate whether someone might be more appropriate for these programs rather than LPS conservatorship before we move forward. There's a couple of other points. We did want to kind of talk about Care Court because, you know, as the public, as the face of the public guardian, you know, we want to be there to help people when they're in need. We see a lot of people though who they need help, but not necessarily to the point where we should be taking their rights away or be petitioning the court to take their rights away to make decisions. And that's where kind of Care Court comes in that it has a lot of elements of the court process. It's a civil court process, just like LPS, except, you know, it doesn't do involuntary treatment, but it uses the court process to kind of persuade people into treatment, using kind of what you guys may have heard of as like a black robe effect. So black robe effect, basically it's, you know, we as a conservator, I'm not going out there with my huge muscles, holding people down and popping pills into their mouth. And, you know, that would be horrible, obviously, right? We have a conservatorship paper that says we are the public conservator. We have powers to involuntarily medicate this person. And the facility will give them reminders. Hey, here's your pill. Here's your pill. Are you going to take this pill? Your therapy starts at 3. Are you going to go to the therapy? I mean, beyond that, the fact that they can't run out of the facility, there's no other forced mechanism unless they get into a psychiatric crisis and they have to get hospitalized. And then maybe they'll get an injectable or something like that, right? So black robe effect is really like this piece of paper is convincing that person that there's powers that exist that they have to adhere to this or else, right? And CARE is kind of, you know, following that formula. So I don't know if everyone on the call has heard of Care Court, but that is something where the public family members, there's a bunch of people who can refer their loved one, if needed, to Care Court to see if they'd be willing to try Care Court, including, it's not just the court process, but the care team can provide clinical treatment, kind of go out and meet like an FSP or be connected to an FSP, a full service partnership, clinicians and other wraparound teams that'll come out and meet you where you're at, right? So that is something that SB 43 also kind of cemented into the law that we do have to investigate for. One of the things that in 2026, they also changed is they added a diagnosis to Care Court. If you remember initially when it was launched, I think it was just schizophrenia or, schizoaffective, like anything on that spectrum. And they added, bipolar disorder with psychotic features, which Dr. Hurley, is that just bipolar 1 or I don't know what exactly it's called, but if you have psychotic features to your bipolar disorder, then that's someone who can qualify for Care Court as well. Moving on, this is the eligibility requirement for care. It's in the slide. Basically, again, it mirrors a lot of the processes of LPS, but the person is more actively involved in their own treatment plan. So there's a lot of not self-navigating, but there's some ownership for that person too in the process. And then obviously in LA County, in Norwalk, there's 2 courtrooms that hear it, and the judges are very supportive of the people who walk in. There's a lot of, praise, admonishments. It's a very, what you would call a therapeutic process, if you can call going to court therapeutic, but there is a therapeutic element to that about Care Court. One of the other things, like we said, we have to investigate for care. The public guardian and the care team are very closely knit. So we meet regularly to even see that where people are doing well on a conservatorship and we see that they may need some, hand holding to step down from a conservatorship, we will work with the care team to kind of quote unquote step them down from a conservatorship to working on a care plan so that their transition can be smooth into the community. This is all the information regarding Care Court. I did want to address a couple of other things about where, some people may have had expectations about locked settings for people who are, receiving SUD only treatment, right? Dr. Hurley did mention they are trying to license facilities to kind of do both. I do want to say that outside of the immediate inpatient crisis for substance use, sometimes it can be two very different populations, right? So you got a group of people now, you're getting, I guess, withdrawal treatment, medication assisted treatment. My mindset of that is usually it's a little bit more serene. I mean, withdrawal is not fun, but you got, a little bit more a calmer group of people. Let's say you have half the room, 15 people getting that. And the other half is LPS. LPS with psychotic symptoms, people are screaming, yelling, they got a lot going on. This is not a therapeutic room for the people who are going to get care just for their SUD symptoms, right? So I think that's where also we just want to temper expectations as to we can get licensed to mix, right? But there's a lot of other logistics that need to be in place, and that the two populations are not necessarily crossing over in terms of the treatment settings, and we want to be very respectful of that because when Dr. Hurley was talking about the 11 elements, and then I was counting I have about 8 of these for caffeine, right? So I'm just imagining myself in a treatment setting. I'm trying to withdraw from a substance, whatever it is, and then you're in a setting where other people are dealing with just totally other things. I think we do want to be careful, especially if we're thinking our loved one needs to go to these types of settings. It may not be what you think it is. And so, again, we're always open to questions, but we do want to make sure that people are not shocked after the fact. And then these are some of the resources. I think our website is on there, as Dr. Hurley also mentioned. And so when you get the PowerPoint, I believe it'll also be linked.